Session of the pain conference, which is the neuropathic pain session. And I would like to invite Professor Dr. Jodat Salim to chair the session. And Professor Dr. Jodat Salim is serving as an additional charge as Executive Director and Medical Superintendent of Punjab Institute of Neurosciences. He is President of PSA Lahore chapter. He is also the faculty member of anesthesia discipline at CPSP. He is member executive committee of MS at University of Health Sciences. He is also the chairperson of level 4 qualifications in the UHS. He is a supervisor examiners in the various institutes. Thank you very much, sir.
Just one correction. Now this first is over. Additional executive director and MS.
And next, I would like to invite Professor Dr. Rafia Tabassum. She is professor of anesthesia and also the chairperson of surgical intensive care unit and pain medicine and certified health professional education. She is diplomate in bioethics at the People's University of Medical and Health Sciences for Women, Nawabshah. Thank you very much, ma'am. And the next, I would like to invite Dr. Michael Serpell, who is consultant at Queen Elizabeth University, Glasgow, for his talk on taking the sting out of the painful diabetic neuropathy. And he is a consultant and senior lecturer in both anesthesia and pain medicine. And he is a leading pain researcher and a writer of multiple books. Thank you very much, sir.
Thank you very much for the introduction, and I'm enjoying this conference so much. Second day here is even better than yesterday, which I can't believe. So thank you all for your really interactive discussions. I've learned an awful lot. So as I said yesterday, I'm from Glasgow and pain consultant there. Sorry, you've seen these. And I will be, are we on to my talk? Talking about taking the sting out of neuropathic pain. Got it? No. Yeah. Okay, thanks. Okay, so my declarations, I have no financial interest in diabetic neuropathy. I'm going to cover these sections in the talk today, a little bit on epidemiology and very brief diagnosis. I'm going to focus on the treatment recommendations, taking the sting, and I'm going to talk a little bit about pathoneurogenesis at the end, because I think that's an area that we can try and impact to try and improve the patient's pain. So the epidemiology, diabetic neuropathy is quite a heterogeneous mixture of different types of neuropathy. It's present in about 50% in all patients with diabetes, and it comes in various forms. The most common is your classic peripheral sensory neuropathy, the stocking and glove distribution. That counts for about half of the 50%. But you have your other forms, your radiculopathy, your mononeuritis multiplex, and also the more kind of complex autonomic neuropathies, which can affect patients quite adversely. So lots of different presentations. As I say, a quarter of patients will develop your classic sensory diabetic neuropathy. And there's some numbers there from the States, very common, 20 million patients thought to be suffering from it. And if you do have peripheral sensory diabetic neuropathy, you're 15%, 5% chance of going on and getting an amputation. So trying to stop that is a major prophylactic type of strategy we should be adopting. A lot of different factors can predispose to the patient getting neuropathy, and this is a Sentinel article in the New England Journal of Medicine, which looked at patients, diabetic patients without cardiovascular morbidity. So these were the relatively healthy ones, and they looked at the different risk factors for developing diabetic neuropathy, and you can see that hypertension, for example, increases your chance by 1.5 times. And all these factors are independently predictive of developing diabetic neuropathy. So we must be focusing on these things as a holistic medical force. So trying to sort of reduce hypertension, smoking, Yes, the diabetic control is very important, and also the duration of having diabetes. But then there's these other parameters of being overweight, body mass index, and triglycerides as well. So these are factors which are important to identify in your patient and to try and minimize. And yes, that may well be in the realm of the diabetic service looking after your patient, but you as a clinician should also be reinforcing these factors that the patient needs to optimize to reduce their chance of getting diabetic neuropathy. The diagnosis, any sort of screening tool needs to be simple, fast, and reliable. And certainly the one that we use is the Michigan Neuropathy Screening Instrument. It's got 15 questions that the patient answers in terms of asking about symptoms of numbness and paresthesias in their limbs. And there's 4 factors, objective factors that you assess in the patient's foot. And each foot has potential of 4 points. And they get 1 point if there's an abnormality. And so, for example, if the appearances of the skin is abnormal, they'd score 1. If there's ulceration, they'd score 1. If there's a diminished reflex or absent reflex, they'd score half or 1 point. And if there was vibration loss, again, they would score points. So scoring 2 out of a possible 8 points is fairly predictive of having sensory peripheral diabetic neuropathy with a sensitivity and specificity outlined there. So it's quite a simple, nice, robust tool to use. Getting on to the treatments, I'll be focusing on drug treatments primarily, monotherapy, talking a little bit about combination therapy. But at the end, I'll also be talking about targeting the neuropathology. So we're focusing on the symptoms, the hurt that the patient has, and predominantly this is medications, which I'll go into more detail, but be mindful of the pathoneurogenesis and the abnormalities going on, and that we may be able to modify those to have secondary indirect benefits on decreased pain. But I'll come on to that near the end. In terms of medications for diabetic neuropathy, for all types of neuropathic pains, the predominant ones are the 3 antis, the antidepressants, the anticonvulsants, and the antiarrhythmics, such as lidocaine, for example. We do have some other things like capsaicin cream, query opioids, very low role, but these are options we sometimes have as well. What I did was take a recent sort of synopsis of what the most up-to-date recent guidelines promote, and there's 3 different selections here. The American Diabetic Association, Diabetes Canada in the middle column, and the UK NICE guidelines on the right-hand side. And you can see that they're very similar. They suggest the same type of drugs, the gabapentinoids, for example, the analgesic antidepressants, predominantly duloxetine, and maybe some alternatives such as nortriptyline as well. The Canadian one and the UK one do mention topical therapies such as capsaicin, so there's slight variance, but they're very, very similar in most of their main recommendations. What they all do say is really, in terms of opioids, we've heard this before, for non-cancer pain, opioids have very little benefit, but sometimes we do need to use it. They advise against using it. If possible, use everything else, but if you do have to, then there is some weak evidence that perhaps using opioids, which have an additional activity, not just the mu opioid receptor, but also affect noradrenaline and 5-HT, such as tramadol and tapentadol, that they may be the more appropriate ones to use. But by and large, opioids are not recommended. So in more detail, this is the NICE, the UK neuropathic guideline. Is for all types of neuropathic pain, not just specifically diabetic. And this is the way they have finalized their recommendations. It was updated most recently in 2020, having first been produced in 2013. And you can see that the 4 drugs mentioned there, amitriptyline and duloxetine, gabapentin, pregabalin, of 4 drugs they suggest you try in sequence. They don't recommend which one you try first. They just say, these are the 4 drugs you should try, work your way through them. Only after that, they mention combination therapy as an option, but they said they can't recommend it. It's not evidence-based. And the most recent review I could come across on evidence-based for combination therapy in neuropathic pain, again concluded it's not sufficiently proven to recommend. But as clinicians, we would often try it. The other options are to consider capsaicin cream, topical, tramadol, as I mentioned, only for short periods for severe acute pain. And the NICE guideline doesn't actually recommend or doesn't even mention lidocaine plasters. So this is the NICE guideline. I'll talk in details about the particular drugs. Just to go back, as I say, they don't say what order you should try these, but there are differences in these types of drugs that the clinician should be able to tease out what he thinks would be more favorable for their patient, taking into account their comorbidity and other potential side effects. So, for example, with the analgesic antidepressants, we'll start with amitriptyline, which is the golden standard. It's a very old drug. It's a tricyclic. Yes, it works on noradrenaline 5-HT. That's the pain mechanism there. But it also has muscarinic side effects, causing blurred vision, urinary retention, precipitating glaucoma. It's also got histamine effects, which can cause drowsiness and sedation. And it's also got alpha blocker effects, which can result in postural hypertension. So these are potential problems that we see with amitriptyline. The secondary amines, such as nortriptyline and imipramine, we often use as surrogates instead of amitriptyline if we think these problems are likely to occur in the patient or if they actually are happening to the patient. So they're another option to try. But obviously the duloxetine therapy, a newer drug, has less side effects, doesn't affect any of these domains here. You know, it has the normal side effects, but it's a drug which is probably cleaner and less likely to be a problem for the patient, and is usually the preferred analgesic antidepressant to use in patients. Your normal antidepressants, serotonin selective, really don't have any or very weak analgesic properties, so they shouldn't really be used for analgesia. So this is why you might choose one analgesic antidepressant over another. You might try duloxetine rather than amitriptyline. I would say if someone's having trouble sleeping, which they often do, maybe a sedation one like amitriptyline or slightly less sedating nortriptyline may be more advantageous than duloxetine. But if sedation is already a problem, patient needs to be awake and alert, they've got a busy job, then using the least sedating duloxetine would be my first choice. The gabapentinoids, a lot of people think gabapentin and pregabalin are very similar. Pharmacologically, they are different. Pregabalin has first order absorption characteristics. So in the white circles, you can see that what you give is absorbed in a linear way, whereas gabapentin has zero order and it's saturable. So it's much more variable in terms of absorption. So pregabalin would be much more reliably titrated and known to be absorbed. Somebody with small bowel syndrome or inflammatory bowel disease, more problems with absorption of the drug, I would definitely go to pregabalin as my first choice rather than gabapentin. The other thing is that if you don't get any benefit with one of these drugs, there's evidence that changing over to another one, you can get a different result in 25% of the cases. So it is worthwhile trying rotation from one to another if the first one isn't successful. The other thing about pregabalin in particular is that there is a dose-response effect. And we took the 6 different trials in neuropathic pain. Yes, they included diabetic, but they also included other ones. But there was a clear pattern that the higher the dose, the better the pain relief. So if you're just 150 milligrams a day of pregabalin, you get a drop in pain score. But if you go up to 300, it's better. 600 a day, even better. So if the patient is tolerating the drug, do take it all the way up. We see a lot of people stuck on a low dose and they've never tried going higher, and yet they're tolerating it. So if pain relief is not sufficient, do increase the dose. The other thing is what's simpler to use, amitriptyline type drugs once a day, whereas gabapentin, it's 3 or 4 times a day, so that can be confusing for the patient. They're on a lot of other medications as well. So sometimes that factor itself is important. And I would say that if you needed to get rapid control, probably I find pregabalin works better. You can titrate it up quite quickly every half week or even quicker, 4 steps, and you are up on the top dose as long as the patient is tolerating. So to go back to the NICE guideline, you've seen this. What we practice in Glasgow is slightly different. Same 4 drugs. We recommend lidocaine plaster, and we suggest a sodium channel anticonvulsant if you're really getting no response to the pain. But otherwise, just for comparison, that's NICE. No mention of lidocaine and tramadol only in capsaicin, and we have those 3, but we're suggesting also lidocaine plasters. So that's what we do. I'll explain the color coding now. If a patient has comorbidity, and most of our patients have anxiety and depression, it makes sense to try and get 2 birds with 1 stone. So if there's depression, if they're feeling blue, I would tend to go for an analgesic antidepressant as my first drug. If there's anxiety, then it would tend to be duloxetine or pregabalin because they've got proven efficacy in that condition. Most of our patients, though, are depressed and they're on antidepressants anyway, so you need to think carefully about that. A lot of them have some pre-morbid mental health conditions, so they've been on antidepressants for a while. In that case, if they were on a SSRI, for example, not good for pain, I would be writing to the psychiatrist in charge of their case saying, as a pain clinician, I'd be thinking about bringing this analgesic antidepressant in at some point. Can I get your feedback? Was this something that we could do? Is their mental health reasonably stable that you'd be happy for us to do that? Or is it a no-go area while we get on with the other therapies? So that's how we've adapted. The other thing we've done is also looked at the contraindications the relative contraindications or the side effects that the drug you may be thinking about using might bring to the patient. So, for example, any liver or renal problems would put a bar on using amitriptyline and duloxetine. If there are cardiac issues, again, you'd be very adverse about using amitriptyline, so you'd be staying away from these drugs. And if peripheral edema is a big problem, then obviously both gabapentinoids. So that would be our sort of way of trying to tease out which out of these 4 drugs might be the one we go for first to try and deal with this, or to try and avoid that. But all along that line, we would be saying topical therapies are definitely an option from the word go. In the Canadian guidelines, you know, it's left until all other treatments have failed. But I would say if there's a topical therapy available and your patient is unwell, frail, multiple comorbidities, which a lot of diabetic patients have, why not go for a therapy which has minimal side effects systemically and see if that works. And if it does, you don't have to bother with a medication. So getting on to combination therapy, the combination trial is one that was published in 2013, but very, very good. It focused on the first part, which was just monotherapy, halfway dose of duloxetine or halfway dose of pregabalin. And the second part of the study, if they didn't get 30% or more pain relief, was to either add in the drug from the opposite group or just stick with the same drug but take it up to the full dose. And what they found was that the combination therapy, and this should be week 16, that's week 8, the single therapy, they both improved. If you changed over to the combination therapy, it was no better than sticking with the monotherapy, but taking it all the way up. So based on that, they couldn't recommend combination therapy because monotherapy, as long as you took it all the way up, did as well. The second thing they found out was, and this is in the first part, the first 8 weeks, was that actually duloxetine at halfway dose worked better than pregabalin at a halfway dose. So you would probably choose duloxetine as more beneficial than pregabalin on that basis, if you're just taking it to halfway. In terms of side effects, well, you tended to have less dizziness with duloxetine, but you had more nausea. Same degree of side effects in terms of sedation. So different side effects depending which drug you used, but overall similar side effect profile in terms of patients having to stop. And what they did show in this study that duloxetine at 60 worked as well as the top dose of 120. So they would recommend don't take the duloxetine any higher, but with pregabalin going up from 300 a day to 600 a day, as our meta-analysis showed, you did get further improvement in pain control. So just to finish up on the pathoneurogenesis, dealing with what's going on, as I say, we know that these are individual predicting factors. So yes, target the glucose and cardiovascular risks. And what's the evidence for that? Well, very conclusive. In type 1 diabetics, if you do tight control, they've shown that you do decrease or prevent diabetic neuropathy for years after the study has been done. So definitely for type 1 diabetics, get the diabetics to optimize diabetic control. For type 2 diabetics, that doesn't work. But general good healthy living like exercise and weight loss, there's good evidence coming out that that makes a difference. So we would definitely promote going for that. A lot of problems are happening due to increased glucose, which spills over, causing all these other things. There are mechanisms to attack increased levels of sorbitol or increased levels of reactive oxygen species. And we heard this morning, alpha lipoic acid, that's the best evidence for targeting malformations, and it is it's been shown in trials to be effective, but yet it's not found its way onto any guidelines. But this is definitely something that I would think about in resistant patients. Aldose reductase inhibitors have been out for decades, lots of side effects with them, so they've not really come to fruition. But this one drug has been licensed in Japan, so these are drugs that in the future I think may play a bigger role. So just to finalize, by diabetic peripheral neuropathy, painful, 25% of our problems, use the neuropathic drugs, take them up to the maximum dose. Combinations, I would certainly try it, although they're not recommended, and get your diabetic team involved to try and optimize the patient's diabetic control and other comorbidity. And keep an eye on these areas because I think they will come to fruition. So on that, I will finish and thank you very much for listening.
Thank you, Michael, for this wonderful talk covering all the aspects of diabetic neuropathy treatment options. And we'll take question at the end of the session.
Thank you, Dr. Michael. And let's proceed to the next talk by Dr. Mohjir Baloch, the talk on Quetenza patch therapy, turning down the heat on the neuropathic pain. Please welcome Dr. Mohjir Baloch.
Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you very much for inviting me back after hearing my first talk on Botox yesterday. And I was wondering how I could link both of these together. So I think Botox and Quetenza follow, or Botox and capsaicin follow the 4N principle. So they're both natural, they're noxious, they're neuropathic relievers, and they're also notoriously expensive. So with no further ado, let's get started. So declarations, no financial assistance. Some of the information comes from Grunenthal, which are the people in the UK that makes Quetenza. Just out of interest, who here in Pakistan is using Quetenza? Not Quetenza patches. All right. Okay. So what I'm going to be talking about is I'm going to be touching on the mechanism of action. We'll look at its uses. I'll present some of our data just to give you an idea of the real world experiences, and then I'll go over some practical issues. So when hopefully you do start having Quetenza available, you'll know some of the tips and tricks that we've discovered in our service over the years that can help you treat your patients. Right, so capsaicin, chilies, is something we've been using for centuries to help with pain. Since the 1850s, they've been using hot chili extracts. And of course, I'm sure you have capsaicin cream available. And really the cream, which I love the cream. I think it's a great product. It's cheap as chips. It really only has modest benefit in PHN, post-herpetic neuralgia, and in diabetic neuropathy, and also in MSK pain. And really, the problem is you put the cream on and then everything gets contaminated because it sticks to the skin, it then sticks to your bedclothes, then people rub their eyes and it's all over the place. So what we find really is with the creams, they're not that effective, they get everywhere and they cause all sorts of problems. So there's poor patient compliance. So really, if you like, the race was on to try and find something that was far more targeted and far more effective. And the story really starts in the late 90s when Robbins's group decided to use extra strong 5 to 10%. Remember, the cream is 0.025 to 0.075. This is 5 to 10% cream. They use 5% as well as 10% in patients with bilateral peripheral neuropathy. And the way they did this, because it was so irritant that they had to put epidural in to cover the areas that the cream was being applied to, and they had to use special airborne decontamination when they were doing this study. But they found that there was a 50% reduction after single application, and that lasted 50 weeks. A single application of this really, really strong capsaicin cream, and they were getting prolonged relief. So on the back of that research, this Quetenza 8% capsaicin patch came about. Now, what is it? Well, it's a topical agent that provides a rapid delivery of potent capsaicin with minimum systemic and environmental exposure. And we'll talk about that later. FDA approved back in 2009. And the size of the patch is important. Bear that in mind. So it's about so big. So it's about this big, just to give you an example of the size of a patch, slightly smaller than a UK letterbox, because you can use 4 patches maximum at any one stage. So how does it work? Well, let's get this pointer. It'll be easier to see with the pointer here. The way that it's working is on these TRPV1 receptors here that you find on the cell membranes. And if you remember your physiology and pharmacology lectures back in medical school, these are the receptors that respond to pH, they respond to temperature, and they respond to leukotrienes, and they're calcium ion channel receptors that then have an effect on the ER and on the mitochondria. And importantly, what capsaicin is doing in terms of the patch, so if you use a high concentration of capsaicin, it is causing prolonged activation of these receptors. You're getting the intracellular calcium going sky high, and that's then causing dysfunction of the mitochondria. And of course, the mitochondria are the engines of all cells. And if you cause dysfunction there, you cause destruction of the neurons. And specifically, these receptors are found predominantly on your C fibers and on some A delta. And of course, as we know, those are the fibers that are involved in neuropathic pain. Now, this is a really interesting slide, or anyway, I find it quite interesting. I don't know whether you lot will find it interesting or not. What this is calf biopsies. So what they've done is they've taken calf biopsies from, well, I presume it was from some sort of animal. But this is A, which is at baseline. Then they apply the capsaicin patch to the skin. And then they take another biopsy at day 3. And then this final biopsy is taken at day 54. And I don't know whether you can see, certainly those in the back, but these black lines are specially stained receptors, those TRPV1 receptors that we talked about that are found on the nociceptive nerve endings, these are shown up in black. Now look what happens. You can see them at baseline. You can see them quite clearly at baseline, but within a day or so, they've gone, disappeared, not there anymore. And then if you leave it long enough, 54 days, they start growing back. So what we've done is we've done something that's disease modifying. We've got rid of physically got rid of or defunctioned the thing that's causing the problem, the neuropathic pain. And when we talk about the effect of the capsaicin patch, we say defunctionalizing the nerve terminals. And Professor Anand at Imperial was a person that did a lot of this research, and he showed that capsaicin patches themselves are causing a defunctioning of the nerves that are involved in neuropathic pain. And that's a bit of a game changer because it's one of the few areas of pain medication where you're using a drug that's disease modifying. It's not just a sticky plaster that's masking the symptoms from the condition. It's actually modifying the underlying disease itself. Right, let's look at the evidence for it. Now in the UK, capsaicin has certain indications: postherpetic neuralgia, HIV neuropathy, which I don't personally see very much of, and then Mick has already spoken about diabetic peripheral neuropathy. And what I've done is I've selected some of the larger studies, some of the more landmark type of studies. There are a lot of studies actually ongoing for various indications, but we have very good evidence for PHN, HIV, and diabetic peripheral neuropathy. They all reduce pain scores. There are smaller studies. In fact, tomorrow I'll be talking at Shaukat Khanum about CIPN, so that's chemotherapy-induced peripheral neuropathy. And I've certainly used it in CIPN in my patients. Post-surgical pain, the big one that we've seen, one of the previous lecturers talked about post-mastectomy pain. 60%, up to 60% of your post-mastectomy patients get post-surgical pain. It's a neuropathic pain, it's a localized pain. Does very, very well with capsaicin patch therapy. And we've also used it for post-thoracotomy pain. Again, that is a high incidence of post-surgical persistent pain. Evidence in ischemic pain. Now, of course, remember, your ischemic patients, a lot of comorbidities. They develop this neuropathic pain through ischemia, and you can really struggle with them in terms of what sort of antineuropathics you can put them onto, but there's evidence for that. And then finally, non-freezing cold injury. This will probably apply to those that are in the military. Ours is a part military hospital. This is trench foot. You heard of trench foot? We see it in the Afro-Caribbean population. They've got poor capillary perfusion because of the nature of their physiology. They get sent out to very cold environments, and they get this really, really terrible neuropathic pain in their feet and their hands, and that's non-freezing cold injury. And again, I've treated patients in our service with Quetenza. Okay, well, 8% capsaicin, 1.6 million times the strength of Tabasco sauce, so this is hot, irritant stuff. What about the side effects? So actually, considering it's pretty noxious stuff, what are the side effects? Well, erythema is very common. The skin goes red, unsurprisingly. Yes, they do get pain. Remember, they've got neuropathic pain. Often they'll have concomitant allodynia, and then you're applying this strong noxious agent to that allodynic area. So of course they are going to get pain. Usually it's fairly well managed, and I'll show you some of our data with regards to that. Bit of itching, hypertension. Some of them get hypertension, and I'll show you what we do in terms of monitoring, because you've got to monitor their blood pressure when you're applying the patch. Okay, so in preparation of this talk, I got my pain fellow to look at our data. And again, 24 months worth of data like I presented last time for the Botox. So this is N equals 15 are the new patients. We've got a cohort that are coming back every few months, but these we looked at specifically with the new patients that are coming into our service. And again, remember, as I said yesterday, 250 new patients that we're seeing for all types of pain referred into the clinic every month. So these are small numbers. They're selective patients. You're not going to use this for every neuropathic pain patient, but for the select few, it can be quite effective. And so over that 24 months, we found 15 patients. Our patient cohort, actually, the majority had some sort of small fiber neuropathy. We had some diabetics. We had, of course, the post-herpetic neuralgics, and there were 1 or 2 that had post-surgical pain. I think both of the post-surgical pains were mastectomy patients. Very good results. Again, this is not a study, it's just an audit. I'm just showing you what our data is like. And actually, having done this now, I've been doing Quetenza now for the last 10, 11 years, it can be very, very effective. As long as you select patients very carefully, it can be very, very effective. And it's the closest to a silver bullet that we have in pain medicine. Targeted, focused, very few systemic side effects. We didn't really have anyone that said that the effects were so terrible that they'd never consider having it again. One patient had intense pain for 72 hours, but that settled down, and then they came back for a repeat. And so what's our protocol for when we're thinking about managing localized peripheral neuropathic pain? Where does Quetenza fit into that? Well, I always start off with the antineuropathics first of all, your gabapentinoids and or the tricyclics. And really, if patients don't benefit from them, I remember we're talking specifically about those that have localized peripheral neuropathic pain. If they don't benefit or they get intolerable side effects, and certainly the side effects is the big thing. Most of these patients have other comorbidities, so they often don't tolerate the antineuropathic agents. Then we think about using Quetenza. And then our nurse, after, or actually before they're put onto the Quetenza therapy or given the Quetenza patches, our nurse provides them with an information pack. So with all these things, just like Botox, we talked about patient engagement, patient information. You preempt the questions that they might have, the concerns they might have, by giving them information. And so they provided information, and then they have the patch applied as an outpatient service. It's a nurse-led clinic. The patches have to be supervised by a clinician, but I'm usually next door running my clinic, and the nurses do all of our Quetenza patch therapy. They then follow them up at 6 weeks, and they ask the question, did it provide you with 30% is what we regard as a positive effect. If it did, we repeat it, usually every 3 months. Certainly they're followed up every 3 months. Some patients, a bit like the Botox, some patients get longer than 3 months. So we've had them where they've gone 4 months and 5 months. Some of them stretch to 6 months. And we have a cohort been coming back almost from the beginning of when I started the service. Nothing else worked for them. They find the Quetenza is very effective, so they carry on having it. Now, if they have one lot of Quetenza and it doesn't work, they are offered a repeat. So if it doesn't work the first time, it's definitely worth trying a second application. So it doesn't work first, and the patient says, look, I don't mind trying it again, offer it. Because we definitely have a cohort of patients that don't respond after the first treatment, but they then do respond after the second and subsequent treatments. The manufacturers in the UK are pushing for a third trial. I think they're just trying to, pull a fast one by making a bit more money, but certainly second offering of a second application, I think is very reasonable, and that's what we offer in our service. If that doesn't work, then we go on to other modalities. Okay, I'll let you take your call or whatever you need to do. So who do we not do it in, or where do we not do it in? We don't do it on the face. If it's broken skin, that's a big no-no for obvious reasons. If the numbness is more than the pain, it's not going to work. If it's a big area, I've said 4 patches is the maximum you can apply at any one sitting. And remember, the size of the patch, size of a letterbox, so just bear that in mind. Uncontrolled hypertension, because it can cause high blood pressure, or if they've got other underlying, certainly unstable angina, but respiratory disease. You see, when you open that patch up, when you open the packet up, even though we are wearing gloves, nitrile gloves, we're wearing a mask, we're wearing aprons, when you open the patch up, you do get a whiff of it in the back of your throat. It's really, really quite irritant. So you just have to be careful. It has to be done in a ventilated room. So if they've got underlying respiratory condition, then you have to be careful. Severe anxiety, obviously, treatment phobia. We try and allay that beforehand by giving them the information, and not licensed at the moment in pregnancy and children because it's never been tested in them, but there you go. Okay, few more practical points. We let them know about the skin irritation. We let them know that it might increase the pain initially, and of course the blood pressure we talked about. I've talked about the information pack, which includes a pain diary as well as all the information about what they should do after they've had the patches, how they should wash and clean themselves, etc., because it can be irritant for a few days. It does take a couple of weeks for the full effect to kick in, so it's not going to kick in straight away. It's going to take a bit of time for the effect, if it's going to work, to kick in. Get them to wash their feet. This is a real bugbear. I don't know why patients don't come having their, their areas washed. If they've got dirty feet, it's pretty disgusting for the nurses, and also it means that there's an extra layer for the patch to penetrate through. Get them to wash their feet. They come accompanied just in case something happens to them. We use cooling packs afterwards. We don't use the EMLA cream beforehand. We used to use the EMLA cream before we apply the patch, but we often found that made the patch application a bit more difficult in the sense the patches didn't stick very well. And we actually find that the EMLA doesn't really add much to the equation, so we don't use any EMLA or local anesthetic cream before applying the patch, but we do use cooling packs once the patches are removed. And there is a special cream that comes with a patch that removes any chili residue that you should use. They avoid bathing or going into sunlight or using exercise for at least for the first 24 hours and then up to the first 48 hours after the patch has been removed. We get them to wash their bedclothes because there can be potentially some residue, but usually we find with good cleaning and the use of that removal cream, that's usually not a problem. From our point of view, as I said, it's nurse-led. We do all of them now in outpatients. We just open the window. That's all you need to get some ventilation in the room. We use gloves, apron, and mask. We don't use that. Some people do. I have to say, for someone who is very allergenic, I used nitrous, gas and air, before I apply the patch. That was really the only way that we're going to get the patch on. And that chap comes back every so often, and we have the nitrous available. We tried Oromorph with him, but it didn't work. But the nitrous works a treat. And it obviously comes out of the system pretty quickly once the patch is removed. Remember, the patch is only going to be put on, I'll show you that later, for up to a maximum of an hour. When you're removing the patch, you want to reduce the aerosolization, that is the chili that's coated on the inside. So always roll the patch inwards like it's showing in this diagram so that you don't have the exposed bit of the patch going out into the environment. And the other thing that we do, which is really good for the patients actually, is use some medical photography to show them how over a period of time the area of pain has shrunk. Because sometimes patients think, oh, I'm still in pain. But actually when you topographically show them that, look, you've had 3 patch applications, look at the size, it's actually shrunk down. We see that as being a very positive educational aspect of the patch application, and it really reinforces to the patient that the treatment's working. And as I said, for duration of application for postherpetic neuralgia, it's 60 minutes, and for diabetic peripheral neuropathy, it's 30 minutes. To be honest, certainly for the post-surgical patients, we get them to keep it on for as long as they can, up to an hour. So some can tolerate the hour, some can't. All right, so in summary, it's an effective treatment for localized peripheral neuropathic pain. It's well tolerated, as I showed you our data and also the research data as well. It has long-term benefits, 3 months, potentially even more, and it's disease modifying, and it can work where your anti-neuropathics haven't worked in the past. And I've got 20 seconds left. So quick plug was in my last 20 seconds, which is as part of my role for the college, we are trying to encourage pain trainees from overseas to come and train with us in the UK through the MTI scheme. So if you have anyone who's done the FCPS in pain, who's a young budding pain clinician, wants to get some training in the UK for a couple of years, please give them my contact details. Thank you very much indeed.
Very nice and informative talk from the learned speakers, but still it's obvious that neuropathic pain possesses big challenge because it exists beyond the peripheral and central mechanisms, and novel modalities they are coming in for the management, but still a challenge though there is existence of the various tools, as the earlier speaker said. and I hope the next speaker will again is going to enhance our knowledge about the
Thank you.
neuropathic.
Thank you very much, ma'am. Our last speech of the day is Entrapment, Neuropathy, and its management by Assistant Professor Dr. Sarfraz Siddiqui, a consultant at Aga Khan University Hospital.
Assalamu alaikum. I'm Dr. Ali Sarfraz. Thank you for the introduction. So I am here to present. I'm very thankful for the chair and the organizing committee to give me the opportunity. Although it's a last lecture, but I will make it crisp and case specific so that you may not get bored. So the topic is entrapment neuropathy and its management. It is very common in our routine clinical practice and patient presenting in the pain clinics. So I am, as mentioned, assistant professor and program director of pain medicine at Aga Khan University. It's a university where I work. And I do not have any disclosure to make here regarding my presentation. So I will be discussing the entrapment neuropathy, its clinical presentation, and in the routinely I will focus on the two cases, the acnes and the myalgia paresthetica, the diagnostic and management strategies. So this quote, I love this quote because nobody cares how much you know until they know how much you care, because patient need pain relief. And we have university, patients are referred to us and they have a great hope on us so that they may have some relief. So it's our great duty not only to educate patient, to create awareness, but to get some relief, if not all. So regarding entrapment neuropathies, as we know, it is a common cause of chronic pain, and it's a day-to-day patient presenting in our clinic. It has debilitating symptoms, and many have some loss of function. And common neuropathies are carpal tunnel syndrome, myalgia paresthetica, tarsal tunnel syndrome, acnes, and motus neuroma, and these are commonly presented to the pain clinic. Regarding clinical presentation, as we know, any nerve that is entrapped, there is firing, extra firing, and patient may present with some symptoms like the paresthesia, pain attacks, hyperalgesia, and allodynia. These are some frequent symptoms patient coming with. And potential pathophysiological mechanism and some risk factor contributing to this can be many in some patient. Usually it's a combination of some systemic disease, the occupational factors, psychosocial factors, some genetic predominance, and some physical factors. So leading to ischemia, edema, fibrosis, demyelination, axonal degeneration, neuronal inflammation, altered axonal transport, and leading to the central nervous system contribution. So it's a lot of things going on with the patient, and usually these patients are referred late to the pain management clinic, making it worse. So it's a great challenge. So I'm presenting two cases. For the first case, the young lady was referred to my clinic by a gynecologist with the complaint of lower abdominal pain and pelvic pain for the last 1 year. And the pain intensity at the time of presentation was 7 out of 10, so it was moderate to severe pain. And the pain was sharp, stabbing in character, and associated with nausea. Pain increased on bending and walking, and unable to perform her daily activities. She was a mother of 2 kids, and she has past history of 2 lower segment cesarean section, 6 years and 4 years back under spinal anesthesia. On physical examination, tenderness was positive on superficial palpation bilaterally below the umbilicus in the midline. And on examination, Carnot sign was positive bilaterally. So a bit about Carnot sign for the young trainees. The Carnot sign, basically it is done to confirm whether pain is coming from the superficial abdominal wall or it is the visceral pain. And it's very simple. My patient presented with the bilateral lower abdominal tenderness, local tenderness, and it is very simple bedside test. You can palpate the area where pain is, and you ask the patient to lift both legs, or sometimes legs and head simultaneously, just to tense the abdominal wall. And then if the pain increases, it means it is coming from the abdominal wall. So in the patient, bilateral Carnot sign was positive. A bit about anatomy, because it is related to the nerve entrapment, and as we know, we have a lot of nerves starting from T7 to T12 and L1. They are coming, they are basically the ventral rami, and they are supplying, they're ending into the midline that is below the rectus abdominis muscle, and the L1 is iliohypogastric ilioinguinal. So it is very common. The entrapment site can be at 2 points. One is the superficial, that is just below the skin, and it is rectus abdominis muscle. It can be at this point. This is the nerve coming. Because of the 90-degree, they got entrapped because of fibrosis at this point, or maybe at this point. So while examining, you have to see this, and the intervention will be different, because for this you have to have a trigger point, and for this you have to have rectus abdominis block, rectus sheath block actually. So what we did with this patient, as we know, the prevalence is 5 to 7, 67% in patient referred to subspecialist, as literature says. And we offer proper education, because patient was suffering this pain for the last more than 1 year. So we have to convince, educate the patient that you have this disease and treatment is possible. Education, counseling, and we started with the multimodal analgesia, and I counseled and offered trigger point injection, but at that time she did not give me consent. She was very worried. So I just said, okay, try conservative treatment, then we can follow you. So after a week, on the first follow-up visit, she came with the 20%, just 20% pain relief. So I again counseled her for trigger point injection. She gave consent, so I applied 5 ml local anesthetic of ropivacaine with dexamethasone bilaterally at the maximum tender point. So after about 2 weeks, on second follow-up, she got about 60% pain relief with improvement in routine activities. That was a pleasant surprise for her, because she was suffering from pain for the last more than 1 year. Then I was not convinced at 60%. I said I counsel her for ultrasound guided bilateral rectus sheath block. She agreed for that. So I applied 15 ml of local anesthetic, 0.25% ropivacaine plus dexamethasone 4 milligram on each side. And as mentioned earlier, so in the rectus sheath block, basically we need to deposit the drug. So we need to deposit drug here, deeper. Initially I deposit here, and then second time I deposited here. So it's a very simple block we do in clinic. We put in bilateral rectus sheath block and deposit drug. We have to deposit drug below the rectus abdominis muscle, between the muscle and the posterior rectus sheath, as you can see here. So it was a simple procedure, and the follow-up visit she got more than 90% pain relief and resumption of daily routine activities. And pain medication is stopped after about 2 weeks then, and till that time she got 100% pain relief with excellent patient satisfaction. So and she remained pain-free for the next 6 months follow-up period, and then no point to follow again. So it was first case in my practice. I just talked to the gynecologist, and the gynecologist team, it's a matter of collaboration. This case was the starting point of collaborating with the gynecologist, because gynecologists are very different, and to accept the anesthetist or pain physician as an entity or as a service. So they invited me in the chronic pain, pelvic pain webinar, where again I discuss a lot and create awareness. And from that point, again, after every second week, I got a patient with some acne. So collaboration really leads to the, awareness that it's an entity, and again, it is helping a lot of patients. In the literature review, we see that repeated local anesthetic and steroid injection, complete recovery is possible, and repeated injection of bupivacaine and steroid provide long-term pain relief in 78% patient. Fortunately, that patient was in that 78, so she got about 100% pain relief. In the review of literature, it is mentioned they shared the algorithm that start with if the cardinal sign is positive, you apply local injection with or without a steroid. If the patient get pain relief, you can repeat injection. So 2 to 3 injection can be repeated, and if it recur, you can repeat injection. Usually they say every 3 to 4 days or at least a week, repeat 2 to 3 times. If the pain is still there, then you can proceed with the either radiofrequency ablation or neurectomy. So regarding this persistent pain, patient who report pain even after 3 injections within 1 year, chemical neurolysis with phenol or alcohol is there, or you can do pulse radiofrequency. Again, it is a difficult thing to search, but it is recommended in the literature for recurrent pain. Ultimately, if the patient do not respond, then surgical release, the anterior neurectomy is mentioned in the literature, patient not responding to any other treatment. And literature show that 50% pain reduction in 61% of patients after primary anterior neurectomy. So these are the complex cases and recurrent not responding to conventional standard treatment. So we published this case report in Index National Journal after that, and we are planning to report case series afterwards. Regarding case number 2, like myalgia paresthetica, a 35-year male presented to my clinic with complaint of moderate pain over the right anterior lateral thigh. As we know, it is the entrapment of lateral femoral cutaneous nerve. The pain intensity was 6 out of 10, sharp and shooting pain. Based on history and examination, working diagnosis of myalgia paresthetica was made. The patient was consulted and conservative treatment started with multimodal analgesia, including anticonvulsants. Then we followed the patient. Fortunately, after diagnostic block, the pain was more than 60% improved, so no need for further. But again, just for the completion of the topic, the myalgia paresthetica or lateral femoral cutaneous neuralgia, as we know, the entrapment of the lateral femoral cutaneous nerve of the thigh, because it supplies the lateral and anterior part of the thigh. The patient is a pure sensory nerve. It's a pure sensory nerve. So pain and discomfort on the lateral and anterior lateral thigh, usual presentation. The word myalgia, the Greek word myros means thigh, algo means pain, and incidence is 3 to 4 per 10,000 person, and male are more prone to this. As we know, lateral femoral cutaneous nerve, the root value is L23 from the lumbar plexus, and the nerve move in the pelvis, lateral border of the psoas muscle, and crossing the iliacus muscle anteriorly and just medial to the anterior superior spine. It comes into the thigh, and then here usually it moves below the inguinal ligament into the thigh and over the sartorius muscle. It's important because we know that there are a lot of variation. 5 common variations have been reported in the literature. The most common is this, that the nerve just 2 centimeter medial and inferior to the anterior superior spine is the most common presentation, but it can move away from this, it can be far from this. But usually it is in the 60% cases it is related with the anterior superior spine, medial and inferior. So anatomical variation is important. That's why in the literature they support that ultrasound guidance can have a better effect. You can do landmark guided, but ultrasound guidance is recommended because of these variations. And as you know, the risk factors of this condition is the obesity is common in obese patient, pregnant patient, tight fitting clothings, leg length discrepancies, or your patient may have pelvic mass. They have more chances of damaging this nerve, and some metabolic factor. Diabetic patients are more prone to have neuropathic pain everywhere in the body, including this, alcoholism and lead poisoning. And surgical risk factor, patient may present with the lumbar spine surgery, pelvic osteotomies, or lower abdominal pelvic surgery. After these operations, patient may report this symptom. So clinical diagnosis is important because diagnosis will guide you towards the proper treatment. So usually patients have complaint of burning pain, numbness, tingling or dysesthesia, there's allodynia, touch is causing pain because of the hyperalgesia in the lateral and anterolateral thigh. Pain is often exacerbated by prolonged standing, walking, and due to tension in the inguinal ligament because of any reasons. So diagnosis is clinical usually, and they just the percussion, tinal sign, percussion at that point can exacerbate pain. This is the clinical diagnosis. You can have electrodiagnostic tests, but really in this case is not really worthwhile to do expenses. The majority of patients improve over 4 to 6 months with conservative treatment. Usually conservative treatment is started as the initial, and we can use activity modifying agent regarding all the risk factors I mentioned. Avoidance of compression activities or wearing loose clothings. Physical therapy can aid in this depending upon what risk factor that patient have. And medications like, as mentioned earlier, tricyclic antidepressants, antiarrhythmics, anticonvulsants, capsaicin and topical lidocaine ointment is recommended in the literature. You can use as required. Regarding, it is mentioned that for the diagnosis, accurate diagnosis and treatment, you can have the lateral femoral quetenza nerve block, and it has therapeutic advantage as well. If you have ultrasound, because of the variation, ultrasound is recommended to use. Just put the probe just 4 centimeter, 5 centimeter down in the anterolateral thigh and just trace upward, because this nerve is very superficial, about 1.5 centimeter from the skin. So it's very superficial. So you have to scan up and down. You see, just this is the skin and this is nerve. And nerve splits anterior posterior division very soon. So it's very about 1 centimeter from the skin, maybe 1 or 2 centimeter. So just you have to scan. This is skin, and as you can see, this is sartorius muscle, and this is the nerve, lateral femoral. Just diagnostic block, and then you can follow. You can repeat the block after 1 week or 2 to get some more prolonged effect. So both corticosteroid and local anesthetic for the treatment of myalgia pacifica are clinically effective. If resistant to conservative treatment, you can move forward with the nerve block, apply with or without corticosteroid. Because of frequent anatomical variation, ultrasonography guidance is suggested in the literature, and we use in our clinic. If patient has resistant, because after 2 or 3 blocks, you can offer pulse radiofrequency. It may be done for longer pain relief and modulating nerve firing. And in non-responsive, again, because it is nerve entrapment, so surgical decompression may be necessary, or neurolytic block can be done for resistant cases, as mentioned earlier. So in conclusion, entrapment neuropathies are usually diagnosed based on history and clinical examination. Electrodiagnostic tests like EMG and nerve conduction studies or diagnostic block may be used for confirmation. Management include conservative treatment, nerve block, radiofrequency ablation, or ultimately in resistant cases patient may require surgical release. So it is also very close to my heart that good physician treat the disease, the great physician treat the patient who has the disease. Because in Pakistan, as it is a growing field, so really patient education, counseling, awareness is really, it takes some time, but I do counsel the patient and interact. I always talk to the referring physician, and I also report to physician, so that we have a good collaboration and for the better care of patients. So let there be no pain. So just a small announcement that in our university, we are holding annual conferences. It's an annual program. So this year, on December 15, we have 24th annual pain symposium. So you're all invited. We will contact you, inshallah, on the email. Thank you very much.
Thank you, Dr. Ali Sarfraz. Very elaborative and informative presentation. And I think this is going to be the end of this session.
Yes, ma'am. Thank you very much for sharing your clinical experiences, Dr. Siddiqui. We are running out of time, so we will skip the question answer sessions to the lunch break. And honorable chairpersons, kindly conclude the session, please.
Thank you very much. Before I conclude the session, I would like to say that I'd like to congratulate STSP, especially Professor Khalid Bashir, Dr. Atiq, Professor Liaquat Ali, Dr. Sadaf, Dr. Leena, Dr. Almas, and many other, Dr. Asif Gulkayani, and many other whom I don't know, who are actually running the show behind the scene. This was a very, very successful conference and covering a very well-structured scientific program. I must say this, and the thing which surprised me was the presence of the audience. We are in the last session and the hall is full, and this is a big, big credit to STSP. They have engaged the international faculty as well. They have engaged everyone who is practicing pain in Pakistan. That's very success. That's a huge success. Another thing I would like to mention that I am part of PSA since 2000. And believe me, like 5 to 6 years back, we used to have a 2-hour session for pain, for pain and chronic pain. And it was a challenge to find the good speakers as well as the audience which was actually interested to listen to those speakers. And now in 2024, sitting in this conference, I must congratulate again. And this is a huge success. Big applause for all the team.
I can add that as Brigadier Kiani Sahab has said yesterday, that the salmon and trouts, they are going upstreams and they are reproducing.
Thank you very much, honorable chairpersons. Thank you.